So the provisionals come to you, and these provisions have to be now properly placed back in the patient's mouth after you've done the final preparation of the teeth. The issue is when you are increasing the vertical relation, you already have the possibility of a 3 to 4 millimeters in this case ceramic material which can be placed. So, do you really need to do the occlusal reductions? Always evaluate the clearance before you do the occlusal reduction, because sometimes you might just reduce the teeth as you normally do, not considering that the vertical increase will allow you to easily place the required ceramic on the occlusal surface. I would advise you to place the provisional when you do one preparation, place the provisional in the mouth and anticipate what will be the reduction required. We always learn crown preps the way a standard preparation should be done. And we almost start believing when we pass out as a dentist that this is the way we will prepare teeth all our life. However, clinical situations are completely different. Rotations of teeth, supraeruptions of teeth, mesial and distal angulations because of missing teeth, and then requirement of increasing vertical relationship constantly make us modify the preparation designs. Path of insertions, aesthetics, occlusal clearances, all of this then becomes a significant part of managing that case. Whenever we are doing cases with increase of vertical, we need to constantly take some reference from provisionals that we have made, so that the provisionals now guide us how we need to prepare certain sections of teeth. Without great provisionals, there cannot be a great full mouth rehab case. So the dentist has to really strive to get very, very good results with the provisionals. When you do tooth preparation, you also evaluate the clearance, uniform. You also keep in mind the curve of Spee, the curve of Wilson, what kind of aesthetics you will get in that case, and when the patient is going to go and do excursions, whether there is uniform space on either side. So centric and eccentric both needs to be looked at, and then only you will proceed with the case with your final restorations. The provisionals allow you to look at all of these aspects. So place your provisionals on one side and look at all other teeth with the proposed increase in vertical dimension recreated in the provisionals. Now it's the time to make impressions. So again, you need to go with your elastomeric impression material, take your alginates for indexing it and seeing that impressions are fine. Retraction procedures will help to get you a great margin so that the technician can see this margin. However, you need a good technician, because even if you do all retractions, you will find that sometimes people don't read well the margins, and you always see overextensions, and those issues have to be sorted, because it's not only about making a great impression, it's also about a good technician working on that. With CAD/CAM coming in a big way, and softwares allowing you to make copings, the entire industry is going through a new learning curve, And with the future being with chairside CAD cams, it is getting more and more interesting how dentistry is going to evolve from where we are today, when from a manual non-digital setting we are completely moving into a fully digital setting, whether it is with intraoral scanners or CAD CAM units, and most importantly integrated solutions with adequate softwares working in the interest of clinical practice for the benefit of for our patients. The registration records can be taken in 3 pieces by keeping the provisionals on the left and the right side in place, and the anteriors in place, so that we have proper records, stable records, records which can be predictable and repeatable. And these records can be reanalyzed, reassessed at every stage of your manufacturing process. That means after your castings or coping trials, and also if at all, if there is any error that you have made in the initial mounting, you can correct it at that stage. A correct mounting is essential to make proper castings, because the thickness of the casting is determined by the amount of separation that you have recorded for the patient, as the technician can then build it with ceramic. So it's very important that jaw relation records, intraocclusal records, determining vertical occlusion, all is given to the technician right at the beginning of the case, so that each step in the process of manufacturing is executed to its perfection. The provisional restorations serve in multiple ways. It helps in analyzing aesthetics, assessing function, phonetics, masticatory efficiency, and then once the provisionals are in place for a few weeks and the patient is very comfortable, you can take the bite registration of one side by keeping the other 2 provisionals intact. So here we have 3 provisionals. If you see, we have made provisionals and they are joint provisionals. The final restorations will be independent teeth. So we have 1 provisional on the left side, 1 on the right side, and then 1 in the anterior. So there are 3 provisionals, and slowly you can take intraocclusal records by placing the provisionals back. Mind you, this patient has eaten with these teeth. He is very comfortable. You can check the guidance path. You're looking at canine guided occlusion. You're looking at disclusions. You're looking at a very comfortable solution that you already offer the patient with a provisional restoration. I don't like to proceed if the provisionals are not comfortable or they are not in great occlusion, because it's always difficult then to understand the needs of the patient. So I strongly suggest that you should make provisionals which are as good as final restorations always. That will bring the best dentistry into your practice. The coping trials can be tried independently and then jointly. They're looked for their fit, they're analyzed for the retention and stability, and you're placing copings in opposing arches and evaluating the clearance again, because the layering ceramic material will need certain bulk in centric as well as eccentric positions, and this will depend upon so many factors, and it will differ from tooth to tooth because there are multiple teeth involved. So it's important that the clinician very minutely looks at all of this right at this stage, so that he doesn't go wrong in the next stage. You could always place the castings back and check the interocclusal record again. We have various materials that can be used for these kind of records, and you could use what is suitable. An AluVax could be one of the easiest thing and quite predictable means of recording, or you could use some fancy material as well. It's important to check the final restorations thereafter, because then after this will be a BIS trial. You'll look at the shade, you'll look at the excursions, you'll do fine tuning of occlusion, and then the final restoration again, you'll be checking for occlusal contacts, eccentric and eccentric, gradually asking the patient to move left and right, front and back, clockwise and anti-clockwise, laterally left and right again. And all of these things together will allow you to fine-tune occlusion. Important when you get occlusion you try with your articulating paper is to know which points to reduce and which points not to reduce. And how do you reduce those points? Using a round burr or a burr which can give a little bit of concavity is always better, rather than using a flat burr which can actually reduce much more than what you need in different areas apart from the exact area that you want to remove from. So it's important how you reduce the occlusion anatomy. Try to get all points closer to the central groove and try to reduce those points first, then start looking at what are the obvious points which are bad. Since occlusion is so variable, sometimes you have a posterior crossbite, so many things, it's always going to be customized to a particular patient's requirements, and that's why you need to use at least a 40 micron articulating paper to redefine occlusal schemes and equilibrate occlusion in the final restorations. Please call the patient several weeks afterwards, check the mobility of all teeth, check occlusal points, ask the patient history of what happened in the last couple of weeks, see whether he's using one side predominantly more than the other side. And all of these are very, very important factors, because you increase the vertical and now you want to be sure that you have brought great occlusion to the patient. And now it's time for the final question and answer session.